Welcome, Chair Baylett.
Payment Model Technical Advisory Committee, known as PTAC. I'm Jeff Baylett, the chair of PTAC. Because of the coronavirus pandemic, we're holding this meeting virtually rather than gathering in the Great Hall of the Humphrey Building. Our goal is for a seamless virtual experience, as close to an in-person PTAC meeting as possible. That said, we appreciate your understanding in advance if any technical challenges arise, such as sound delays or background noise. If you have any technical questions, please email our contractor team at ptacregistration@norc.org. Again, that's ptacregistration@norc.org. If you've joined us via WebEx, you can also message the meeting host with any questions. Many PTAC stakeholders are directly involved in responding to the pandemic, and we are thankful for your service to our country. We want to thank providers, support staff, caregivers, family members, and others who are supporting patients during the pandemic. We recognize that it's a privilege to have you joining us today. PTAC is committed as ever to having a submitter-driven process, so I remind you that the committee accepts proposals on a rolling basis. Many potential future submitters may be focused on the pandemic, so I remind anyone that you do not need to worry about finishing your proposal to meet a specific deadline. The pandemic has highlighted many challenges in our healthcare system, in addition to prompting an unprecedented expansion of telehealth. At our September public meeting, we debuted an additional mechanism for PTAC to garner information that can inform our review of proposals and raise awareness on key topics related to value-based transformation. The meeting included a discussion of telehealth and alternative payment models, complete with panel discussions, information on previous PTAC proposals that included telehealth as a component, and a public comment period. Following the September meeting, 3 committee members formed the preliminary comments development team and commenced its review of the discussion. Key points raised at that time, as well from the input that came in via our telehealth request for input, or RFI. Following careful consideration of all of the meeting input and submitted information, they developed a set of suggested comments on recommendations, policy considerations, and research questions that they will present to the full committee today. In turn, the full committee will review what we learned in September and from the RFI and discuss the comments and recommendations we want to convey to the Secretary in a synthesized report on telehealth. The theme-based meeting discussions represent one of several ways that PTAC continues to evolve to meet a changing landscape. We as a committee routinely evaluate our processes so that we remain well-positioned to advise the Secretary on new ideas related to payment models from the field, as is our charge, and so that we can best activate and engage with stakeholders to solicit such ideas and information. We are also called to serve those stakeholders who seek to provide innovative ideas that aim to address care delivery, quality, and payment transformation. To that end, we are exploring opportunities through process changes or other approaches that could expand and enhance our ability to receive a broader array of proposals and further engage with stakeholders. We have a unique opportunity with today's public meeting. We will discuss the input we have received from a variety of stakeholders over the year, in addition to continuing our exploration of telehealth and alternative payment models. As you may recall, in September, we convened 2 different panels of experts to discuss telehealth and payment models. One panel of submitters whose proposals to PTAC had included telehealth, and another of additional experts representing several perspectives. We also issued a request for input to gather even more public input on the topic, and we're pleased to receive many responses. 3 PTAC members who comprised the preliminary comments development team have been hard at work leveraging the holistic insights we learned about and synthesizing them into potential content for a report to the Secretary on telehealth and payment models. As I mentioned, they will present their recommendations and we will discuss how their work will be incorporated in a report to the Secretary. Then we'll wrap up the day with a public comments period. Before we begin our first presentation, I have some announcements to make about PTAC's work and its membership since our last meeting in September. At the public meeting, we deliberated on two proposals, one submitted by the American College of Physicians and the National Committee for Quality Assurance, and another submitted by ASCO, the American Society of Clinical Oncology. We have since published our reports to the Secretary on these proposals, which you can find online. Additionally, I'm excited to welcome two new members of PTAC. Dr. Carrie Kola is a professor at the Dartmouth Institute for Health Policy and Clinical Practice, which is part of the Gesell School of Medicine at Dartmouth College. Also, Dr. Terry Lee Mills is the Senior Vice President and Chief Medical Officer of Community Care. Welcome. They were appointed by the Government Accountability Office in October and have been diligently preparing to participate today. I'm also pleased to announce that PTAC has a new vice chair, Dr. Paul Cassell. Paul is one of the founding members of PTAC, and I look forward to our partnership. Thank you, Paul, for agreeing to take on these additional responsibilities in service to the committee. I'd like to say a word about one of our members who has reached her term limits on the committee since our last public meeting. Dr. Grace Terrell, one of PTAC's founding members, and contributed to the committee's work in many ways, including by serving as PTAC's vice chair for the last 2 years. We're grateful for her service to the committee, especially her vision in designing these telehealth discussions, and we will miss her greatly. I think I speak for all of my fellow committee members when I say that I look forward to our paths crossing again. And now I would like PTAC members to please introduce themselves. Please share your name and your organization. If you would like, feel free to share a brief word about experience you've had with telehealth, our main topic for today. Because of our meeting, because it's virtual, I'll cue each of you, and I'll start with myself. I'm Jeff Bailitt, the CEO of Alteus, a physician services organization. Paul?
Hi, Jeff. Paul Cassell, a cardiologist. I lead population health at New York Presbyterian, Weill Cornell, and Columbia.
Carrie?
Carrie Kalla. Jeff already gave me a little bit of an introduction. I'm an economist at the Dartmouth Institute for Health Policy and Clinical Practice and have a lot of experience with research in payment models and participate in a lot of qualitative and quantitative research about physician practices. My experience with telehealth has mostly been on the patient side, so I'll keep comments mostly about what I've read in the literature. Thanks.
Thanks, Carrie. Jay?
I'm Jay Feldstein. I'm the president and CEO of Philadelphia College of Osteopathic Medicine. My experience with telehealth is that in our set of primary care clinics, when the pandemic started, we had to pivot from in-person to virtual in the span of a week. And it's been a very interesting experience for both providers and patients.
Thanks, Jay. Lauren?
Good morning, I'm Lauren Hardin. I'm Senior Advisor for the Camden Coalition's National Center for Complex Health and Social Needs. My experience with telehealth over the last year has been working with sites around the country who are building models for complex populations, as well as to respond to the social disaster from the pandemic. And telehealth has been integral in all of those across the board, across the community.
Thank you, Lauren. Josh?
Morning, everyone. Josh Lau here. I'm an internal medicine physician and the medical director for payment strategy here at UW in Seattle. My experience with telehealth has been a dynamic one at our organization where, similar to Jay's, the volume of telehealth really swelled in the earliest phases of the pandemic, contracted and has reswelled. And so definitely something that I'm still continuing to think about and work on.
Thanks, Josh. Lee?
Good morning. Lee Mills. I'm a family physician and Senior Vice President and Chief Medical Officer at Community Care, a regional-based health provider-owned health plan in Oklahoma. My experience with telehealth is been pretty deep, both as a clinician using it in patient care, then in medical group operations and administration, organizing networks of physicians, and then on the health plan side, where we continue to support 4,000 or 5,000 telehealth visits per week among our beneficiaries.
Thanks. Bruce?
Bruce Steinwald. I'm a health economist here in Washington, D.C., and I'm looking forward to my first telehealth visit later this year.
Bruce. Jen?
Good morning. I'm Jennifer Weiler. I'm the Chief Quality Officer at UC Health Denver. I'm also a professor of emergency medicine business for the University of Colorado. I'm a co-founder of UC Health Innovation Center, where we partner with digital health companies, including companies that provide remote monitoring services. And with regards to telehealth, I also served for 11 years within the American Medical Association RBRVS Updates Committee, where we evaluated CPT codes related to telehealth services. And finally, as a provider, our health system provides virtual care services for patients within the Rocky Mountain region, and I do that myself as a provider.
Thanks, Jennifer. And I don't know, Kavita. Kavita may not be, she may not be yet joining us.
Not yet.
Not hearing her. We're going to go ahead. So thank all of you. At this time, let's move to our initial presentation. After our public meeting in June of this year, we issued a request for input to learn from stakeholders on how we might expand our review of proposals. All of the responses received are on the ASPE PTAC website, and ASPE staff will present some of the key points shortly. To my colleagues on the committee, after the presentation, we will discuss our reactions and some thoughts on how we could incorporate this information to improve our existing processes. I'm going to now turn it over to Stace Mendel to present on what we learned from the public responses to the RFI. Stace?
Thanks, Jeff. Good morning, everyone, and thank you, everyone, for joining today. It's an honor to be here this morning and report out on PTAC's June request for input. I'm Stace Mendel, and I serve as the PTAC Staff Director here at ASPE. Next slide, please. This RFI was released in June, shortly after the public meeting when PTAC announced its vision. The RFI aligns with PTAC's vision statement, and in particular its vision to activate stakeholders and increase awareness of issues related to payment and care delivery as identified by frontline stakeholders. Next slide. This RFI included 4 questions that were posted on ASPE's PTAC webpage. The first question was, what are the current challenges in healthcare delivery and payment? What is needed to push forward on addressing care delivery issues and alternative payment models? Are there other actual and potential PFPMs that have not been addressed in proposals submitted to PTAC so far? What other factors would be important to take into consideration to inform PTAC's evaluation of proposals, including factors related to engagement and adoption of models? How might a proposed PFPM build on the learnings from earlier models? And lastly, how might care models that are included in the proposals reviewed by PTAC be incorporated in broader models like ACOs or direct contracting? What factors would be important to take into consideration, such as barriers or facilitators for adoption? Next slide. PTAC received 7 responses to the RFI, one of which represented several specialty societies organized by the American College of Physicians. Next slide, please. Respondents submitted comments on several topics regarding challenges and priority areas, including coordination and integration of care across services. For example, comments included, fragmentation in healthcare increases medical errors and poor outcomes, system waste and inefficiencies, and dissatisfaction for all parties. These effects are compounded when patients have multiple clinicians involved in their care. Another comment was PTAC should give priority consideration to models that support and reward high-value interactions across settings. And another commenter stated, one of the central considerations when it comes to existing models is the lack of engagement between specialty and primary care clinicians. Other topics raised in comments signaling priority areas for PTAC included social determinants of health, proposals with specific clinical focus areas including primary care or care for individuals with serious illness, the needs of small or rural providers in the context of APMs, valuation and costs, benchmarking and quality measurement, and provider and patient attribution. Next slide, please. Respondents also flagged for PTAC to take into consideration in their reviews proposals that are for specialists, are about serious illness, address the cost of home care, integrate non-physician providers, engage community-based organizations, engage caregivers, impact underserved and minority communities, increase financial stability for providers, offer upfront investments for small, rural, and primary care providers, and balance quality with savings to avoid stinting. For example, one commenter expressed, there is an opportunity for new models to be implemented or for existing models to expand in such a way that bridges the chasm between primary and specialty care and engages specialists in more robust ways, including by promoting specialist participation in the financial rewards and the risks of the model. Next slide, please. Stakeholders also flagged the importance of stakeholder engagement and activation. One commenter stated, signal that PTAC is a viable path for clinicians to meaningfully participate in value-based care models that directly apply to the care in which they provide. Another commenter expressed, providing scalable opportunities for specialists not previously engaged in value-based care models should be a priority for PTAC and HHS moving forward. These and other comments taken together underscore how the theme-based discussions at the public meetings can help to raise awareness of issues and priorities identified by stakeholders, and that such input, such as that provided via this RFI and proposals themselves, can serve to highlight important issues and specific needs and priority areas in value-based care transformation. Next slide, please. The comments are available on the ASPE PTAC website. The RFI and input received in total is hosted on our website. And I want to thank you again for the opportunity to report out on PTAC's June RFI. And Jeff, thank you and the committee for your service. And at this point, I hand things back over to you.
Thanks, Stace. We appreciate you walking us through all of that information, and we want to thank those who put time and effort into sharing their perspectives with us. I want our stakeholders to be assured that we want to be responsive to what we've heard. So we've already begun to work on digesting the ideas you've raised and thinking creatively about how we can incorporate them into our processes. For my colleagues on the committee, this is just one of multiple opportunities we'll have today to discuss what our community of stakeholders is telling us and how we can adjust our processes accordingly. I welcome thoughts from my fellow PTAC members about the broad strokes of directions we'd like to move in. We can save some of the operational details for later, but I'd like to get your thoughts on any ideas that you have. So I'm just going to open it up to committee members, and we'll have a discussion.
Jeff, I'm happy to start while others are thinking, as Paul. I think there's several themes that came through those comments, but certainly one of the consistent ones I just wanted to highlight was around this primary engagement of primary care and specialists and how to engage specialists in the models. It seems to be an ongoing challenge around the current models, and even we have seen that as we've commented on several of the models that have been brought previously before PTAC. So just wanted to flag that in particular as something that was certainly consistent through the comments that we heard from through this RFI.
Yeah. I also think, Paul, to that point, there's challenges where physicians are in models, particularly specialists already, and if there's a new proposal, you know, how do they figure out which camp they're in or which models they're participating in? That's also been a challenge for the specialists as well. Carrie?
Another thing that's struck me in reading through them was, in addition to what Paul said about involvement of specialists, is about the fragmentation across both settings and different types of clinicians. I think nearly all of them really focused on that and how you can create models that work on fragmentations, not within a silo, but across settings and providers.
Thanks, Carrie. Anyone else?
Along these lines, as Paul again, I just wanted to, again, when we think about that care coordination, the engagement, and as Carrie said, around fragmentation, you know, not only, there's often, again, just to flag, sort of on the clinical model has sort of been worked out, but the financial model. So how do the different specialties in primary care, there's often confusion around the sort of how the finances work. And Jeff, that gets to your point about, you know, if a specialist is in one model and then maybe in another one, and trying to understand how that all works. Sometimes there's quite a bit of confusion around how the finances work around those things.
And this is Josh. I would just, you know, braiding together Carrie and Paul's points about not just specialty and primary care, not just phases of care, but kind of the interaction between the two, right? That the coordination will look perhaps different for primary and subspecialty care in the outpatient setting, in the acute setting, in the post-acute setting. And I think thinking about those as distinct and then kind of creating payment structures around each of those, or kind of working them together, I think is a critical piece.
Jeff, this is Lauren. And to build on what Josh said, also the interprofessional cross-sector nature of the coordination that's occurring now and how that's shifting the way people are looking at payment. So in order to really have a high quality patient experience through the lens of the person, it's involving integrating social services, community-based organizations, and other funding streams. And I think that will be our challenge going forward, is what do those payment models look like when we actually look at it through a community lens and an equity lens.
Jeff?
Thanks, Lauren. Other comments?
One other comment on a little bit of a different topic is that a few of the respondents also mentioned risk adjustment and kind of the inability of risk adjustment to keep up with these models, and thinking about new ways to approach risk adjustment to make these models work better.
Mm-hmm. Yeah, I think that's a good point, Carrie. And also, there's this, I don't want to say disparities, but there are significant differences between the clinic settings. We've also been working with the stakeholders who are in rural or small practices versus urban or academic centers. There are some nuances there that have played through as it relates to the robustness of the models.
Particularly around social needs, I think we're just starting to get into concrete methods of how to adjust for social needs in particular, and some of them mentioned that.
Right. And additionally, I think it would be great to let the public know that we are wanting to make sure that the pipeline for proposal submissions continue. And we understand that part of what we're seeing as it relates to a little hiatus in proposal submissions now could be related, and probably somewhat are related to COVID and everyone hunkered down to address the pandemic. We also want to make sure that we don't stifle the innovation, which was the premise for standing up the PTAC. And so we're working internally to figure out, is there ways that we can sort of engage with stakeholders to foster the ability for the stakeholder community to submit models that may not have all of the attributes that would be required under the Secretary's criteria, but are strong enough in their innovative ideas that we would still want to consider them. And there'll be more to follow on that as we internally are figuring out how that could potentially shape up. And I just wanted to alert the public that we are actively talking about that now, because we do want to make sure that folks out there have the opportunity to submit their ideas and innovations going forward. Any other comments we want to make at this point? All right. So that was helpful. We'll certainly discuss in more detail. We have administrative meetings, the aspects that we are seeing today in a later session this afternoon. I'd like to wrap up and transition to telehealth, this portion of our agenda, and we'll begin by reviewing what we learned from our various sources, including panelists and public commenters at our September public meeting, an environmental scan that was accomplished, and also a different RFI we released about telehealth. Then we'll have a committee discussion period to sift through all of what we've learned to identify the policy considerations and research questions that we might include as comments to the Secretary. So let's start by learning what stakeholders shared in response to our request for input on telehealth and payment models. Committee members, just as we did with the previous presentation, I'd like us to discuss any initial reactions you have, so please be ready to share after Audrey gets done with her presentation. Audrey McDowell is a program analyst and member of the ASPE staff team that supports PTAC, and she'll present a synthesis of these responses. So Audrey, please go ahead.
Thanks, Jeff. As Jeff stated, my name is Audrey McDowell, and I appreciate the opportunity to review the responses that were received to PTAC's request for input on telehealth and physician-focused payment models, or PFPMs. Next slide. Stakeholders submitted 18 PFPM proposals to PTAC that included telehealth as a component, and PTAC held a theme-based discussion on telehealth in the context of APMs and PFPMs during its September public meeting. And then after the public meeting, the committee released an RFI on telehealth to gain additional insights from stakeholders. Next slide. As discussed earlier, PTAC's release of these RFIs is consistent with the committee's vision of providing a forum for encouraging stakeholders to increase both awareness of important payment and care delivery issues, and also to develop important solutions to these issues. Next slide. This is an overview of some of the topics that were addressed in the telehealth RFI, ranging from best practices to performance metrics and beneficiary education needs. A full list of the telehealth RFI questions can be found in the appendix of this slide deck. Next slide. This is a list of the 9 respondents to the telehealth RFI, which included 5 associations, 2 other organizations, and 2 individual physicians. And it's noteworthy that 4 of the respondents were actually previous PTAC proposal submitters. Next slide. There was consistency between many of the themes in the stakeholders' responses to the telehealth RFI and the themes from the September public meeting. The respondents to the telehealth RFI also provided additional insights regarding several topics, including performance-related metrics, monitoring and evaluation methods, and beneficiary education needs. Additionally, the telehealth RFI responses also addressed some topics that were not specifically included in the RFI. Next slide. The following are some excerpts from some of the stakeholder responses relating to the need for measures to precisely define which aspect of telehealth is being measured when considering the impact on cost, quality, and experience of care, the need for telehealth as another site or modality to be held as another site or modality rather than type of care, to be held to the same quality and safety standards as other care settings, and potentially to adapt rather than reinvent quality measures for telehealth. And also the need for robust education to help beneficiaries understand how to use telehealth. Next slide. Regarding next steps, the information from the responses to the Telehealth RFI will be incorporated into today's discussion on telehealth and value-based care transformation, as well as the report to the Secretary, and also in subsequent PTAC environmental scans related to future PM proposals that incorporate telehealth. Next slide. As discussed earlier, the appendix includes the full text of the questions from the Telehealth RFI. Next slide. Next slide. Next slide. All of the responses to the Telehealth RFI are available on the ASPE PTAC website. And that concludes this presentation. I will turn it back over to Jeff.
Thank you, Audrey. That was helpful, and it was a great way to begin the telehealth portion of today's meeting. And of course, our thanks to those who shared those insights with us. Committee members, were there any specific points from the RFI responses that you'd like to discuss at this time before we move into the actual committee's work on the telehealth initiative? All right. Hearing none, I think we'll just move right in then. As I mentioned earlier, PTAC plans to release a report to the Secretary synthesizing its comments and recommendations from our deep dive into telehealth and payment models. As I noted earlier, the preliminary comments development team, which is a new team for PTAC, have focused on synthesizing what we've learned at our September meeting and since then through the RFI. They have created a set of slides with potential comments that we could include in our upcoming report, and we'll walk through it with them today. As a quick disclaimer, their findings do not necessarily represent the full committee's position, and they're not binding. After their presentation, we'll discuss their findings and the extent to which we would like their recommendations to be part of our final report. At this time, I'd like to turn it over to Jay Feldstein, the lead of the preliminary comments development team, who will report out to the full committee the team's suggested comments. At 4 separate points during his presentation, Jay will review the suggested comments for committee deliberation. To stay on track with the day's agenda, we should plan on keeping our deliberations for each segment to about 10 minutes. I think we have maybe a little bit more time since we're a little ahead right now, but needless to say, we'll try and stay on track. Jay, please go ahead. You're on mute, sir.
That's better. Thank you, Jeff. Good morning, everyone. This is our report on our preliminary comments development team findings on the role telehealth can play in optimizing healthcare delivery and value-based transformation in the context of alternative payment models and physician-focused payment models. I'd like to thank my other team members, Carrie Cole and Laura Harden, for their hard work and dedication, and also to Audrey and Stacy, to the ASPE team, for really synthesizing a tremendous amount of information that was relayed to us during our September meeting. And I look forward to sharing our information with you into a robust discussion. Next slide. Today's overview, we'll talk about the background, the preliminary comments, team composition and review process, an overview of key findings relating to telehealth in the context of APMs and PFPMs, and the key issues and potential comments identified by the PCDT. Next slide. On September 16th, PTAC held a theme-based discussion on telehealth in the context of alternative payment models and physician-focused payment models. Hello? On September 16th, PTAC held a theme-based discussion on telehealth in the context of alternative payment models and physician-focused payment models. The goal is to provide PTAC with current perspectives on the role telehealth can play in optimizing health care delivery and value-based transformation in the context of APMs and PFPMs in order to further inform the committee's review of future proposals. The telehealth session included a presentation on the 18 previous PTAC proposals with a telehealth component, panel discussions with 6 past submitters whose proposals included a telehealth component, and a diverse group of subject matter experts, and public comments from stakeholders. Prior to the public meeting, an environmental scan was prepared that provided background information on telehealth, the role of telehealth in the context of APMs and PFPMs, and issues and opportunities associated with optimizing telehealth in an APM. After the public meeting, PTAC released a request for input and RFI on telehealth and developed a supplement to environmental scan on telehealth. Next slide. To prepare for today's discussion, 3 PTAC members of our team volunteered to serve on the preliminary comments development team, and one of us serving as the lead. After reviewing the available information, we prepared a summary table and a presentation summarizing its findings for the full PTAC. Our findings are typically posted on the PTAC website at least 1 week prior to public deliberation by the full committee. Our findings are not binding on PTAC, and PTAC may reach different conclusions from those contained in our presentation. The report to the Secretary will be prepared based on the results of the full committee's deliberation, and this is our flow diagram of our process and where we are today. Next slide. In terms of an overview of our key findings relating to telehealth in the context of APMs and PFPMs, the following of the overview is there are many different definitions of telehealth, whether it be virtual visits, audio visits, telemonitoring. There are various types of barriers that have affected telehealth use. Telehealth use increased during the public health emergency. Increased use of telehealth provides opportunities to improve healthcare. Some best practices for optimizing the use of telehealth services, how to address barriers affecting beneficiaries' access to telehealth, the role of APMs in optimizing the use of telehealth services, and payment issues relating to telehealth services. Next slide. The importance of considering the relevance of potential comments to APMs and PFPMs. Many telehealth issues and potential comments are broadly applicable to both value-based context and traditional reimbursement arrangements. During the committee's deliberations, it will be important to highlight which topics and comments are most important in the PFPM or value-based context. Next slide. We put our comments into distinct categories. Category 1 focused on infrastructure for both provider and beneficiary needs. Category 2 are barriers and enablers, policies related to access and optimization. And Category 3, payment issues, paying for telehealth under physician-focused payment models or alternative payment models. And Category 4, what research questions to address the gaps in our knowledge. Next slide. Category 1, provider and beneficiary needs. How do we avoid disparities? How do we focus on vulnerable populations? What are the provider needs? How do we address standards for adoption and use? And how do we address benchmarks and variation in standards by setting? And how do we understand provider and beneficiary costs? Next slide. What are our beneficiary needs and how do we avoid disparities? Our key observations: virtual care can exacerbate disparities in care for vulnerable populations, whether it be underrepresented minorities or those living at home with long-term support service needs. How do we address those without access to devices, broadband or comfort using technology, and who face a digital divide? and then populations with physical and cognitive impairments to using technologies have special needs as well. From a proposed comment perspective, we need to consider sponsoring a report to investigate or describe unintended consequences associated with widespread adoption and use of telehealth that addresses the potential for exacerbation of disparities in care for specific populations due to the digital divide, cognitive physical impairments, and long-term support services for those living in the community with limited caregiver support. Next slide. How do we focus really on vulnerable populations? Aging or disabled populations with long-term service needs and others residing in the community with limited caregiver support are socially isolated with unmet needs. Visual and hearing impairments and limited caregiver support present challenges to usability. Cultural sensitivity, language translation services, and attention to health literacy are also needed. And addressing the needs of these populations requires strategic care planning to ensure access to adequate virtual care. We need to partner with a diverse array of stakeholders, including providers and those representing the beneficiary voice, on development of standards for adopting telehealth to address long-term service needs of community-dwelling populations and to address the impact of social isolation. Consider further research on unintended consequences of widespread use of telehealth, addressing disparities in care for specific populations, including those with impairments or those who require language translation and culturally competent education. Next slide. How to address provider needs for standards and adoption and use. Telehealth can provide as-needed access to interdisciplinary providers, social workers for patients, staff skilled in nursing care facilities. An APM could support a cultural shift from using telehealth as an event to providing routine access. The rapid adoption of telehealth has led to some providers to adopt new workflows and approaches for determining the need for in-person care. And key strategies include enhancement of team-based approaches and use of telephone or audio-only backup in case of technology failure. Telehealth may exacerbate data silos if we're not careful in integrating it with electronic medical records. From a proposed comment perspective in the context of APMs, considering developing partnerships with a diverse array of stakeholders, including providers and those representing beneficiary voices, to support the development of standards for telehealth adoption, including workflow, service integration, team-based approaches, shifting to a culture of routine access, and determining when telephone or audio-only access is appropriate and sometimes the only technology available, and the interoperability of data gathered in the context of telehealth so we do not create an additional silo in healthcare. Next slide. And how do we address provider needs from a benchmark and variation in standards by setting? Virtual services cannot fully substitute for hands-on care. Payment parity may be appropriate for ensuring access to some services, but may introduce program integrity concerns. Current guardrails to support appropriate protections may not be sufficient. Additional guidelines, quality metrics, and benchmarks may be needed, and different settings, provider types, and clinical scenarios may warrant different standards. We need to consider partnering with a diverse array of stakeholders to support the development of standards for appropriate adoption of telehealth by setting, modified clinical quality measures for virtual versus in-person care, benchmarks using patient satisfaction, measures to compare virtual care to in-person care, and the use of analytic technology to enforce program integrity rules. Next slide. How do we understand provider and beneficiary costs? There's a lack of rigorous methods for accounting for provider costs means true cost of adoption is not known. Variation in costs by geographic area and provider type are also unknown. And beneficiaries may also face costs associated with devices and connectivity. Appropriate APM payment mechanisms to cover these costs require more exploration. And in the context of APMs, we need to consider exploring interest in partnerships, again with diverse array of stakeholders, to support the development of accurate methods to comprehensively account for costs of telehealth adoption and use for different provider types. And we need research on costs associated with beneficiary access to broadband connectivity, technologies, tablets, and technical support needed to benefit from telehealth. Next slide. So at this time, we'd like for PTAC to have a discussion of our suggested comments. In the following 2 slides, we have summaries of what we've just gone through. I'd open it up to members of my team and also Mr. Chairman to give it back to you for a full committee PTAC discussion. So if we could advance to the next slide, which is a summary of what we've gone through, that would be a good place for us to start. Thank you.
Thanks, Jay. And I'd look to Carrie and Lauren if you guys wanted to make any additional comments before the full committee weighs in.
I think Jay covered this well, Jeff, and I think one of the most important issues we saw in the comments and around the country is the importance of really integrating diversity and equity in the way we look at telehealth.
Yeah. Thanks, Lauren. Nice job. Nice job, Jay. We're going to open it up to the full committee. Bruce?
Thank you, Jeff.
You're on mute.
Thank you, Jay. Can you hear me now?
Yep, we can.
Okay, good. I'm referring back to your slide where you identified program integrity as an issue. And I wanted to comment on that a little bit. In full disclosure, I spent 10 years at the Government Accountability Office covering healthcare spending and Medicare spending issues in particular, and have a heightened sensitivity of how certain developments may have spending implications that are concerning. The advancement of telehealth, especially in the context of the pandemic, is terrific. But with rapid growth, there comes the potential for overuse and misuse. And I think we need to look ahead past the pandemic, when we have now an infrastructure installed for much more telehealth in the healthcare system in general, and how we can make sure that that infrastructure doesn't generate additional unnecessary spending. And one comment I would make in that regard, and I know you're going to get to this later, is building telehealth into APMs and PFPMs. It may be one very competent way of ensuring that these services are used appropriately and don't create a real problem for Medicare spending.
Thanks, Bruce. Any other committee members have comments to make at this point? Carrie?
Just to really piggyback on what Bruce said, and I think it's this tension we're dealing with of wanting to create access while wanting to think about program integrity. And also as someone who worries a lot about healthcare spending and its implications on both public and private budgets, I think we also want to deeply consider situations in which telehealth is substituting for existing care, as we saw at the height of the pandemic. Whereas research from before the pandemic showed that a lot of telehealth services were supplementing normal care, in which case that would have a bigger implication for overall Medicare spending. And I think just some considerations to make in that choice, or that it is difficult to determine that based on claims. And so in a fee-for-service environment, it's more difficult to try to parse out which of those scenarios you're in. And so that's why an APM might be more well-suited to this, such as CMMI is using in existing APMs even before the pandemic. And then also that research shows that the effectiveness of telehealth in different clinical scenarios varies. And so allowing providers to really be able to make those determinations is also appropriate in the context of APMs over which clinical scenarios are more effective for use of telehealth. And finally, thinking about the research in terms of telehealth in the context of existing clinical relationships, ongoing continuous care, versus outsourced telehealth to other types of providers, and how those might differ in terms of the outcomes they might produce.
Mm-hmm. Thank you, Carrie. Other committee comments?
Well, this is Josh by phone here. I think the comments by Carrie, I think, are relevant, and building on that and what Bruce said about, APMs and PFPMs being maybe a nice way of focusing on integrity. I think the other perhaps complementary point is that I listened to all the really critical and salient issues that Jay outlined. Some seem that they will be particularly relevant to APMs and PFPMs, perhaps over others, in terms of just implementing these models. And that may also vary by the model. So for instance, to Carrie's point about the effectiveness in different clinical settings and clinical kind of areas of care, you can imagine that how we would design telehealth around a primary care model may be very different than a subspecialty focused model anchored on hospitalization versus kind of a more global population-wide model. So I think there's a lot here. And as we think about, well, what is the potential with PFPMs, the kind of related question is, what are the issues that really drift up to the surface as the most critical ones in each of these models that I think would be good for us as a community to think about?
Thank you, Josh. Other committee members?
Just perhaps to slide us into the barrier section, I think the balance that we're thinking about is the balance between flexibility and lower administrative complexity, which was something we heard from the people who wrote in with the program integrity goals that Bruce brought up. And one of the things we've seen in the pandemic is this relaxation of the documentation and regulation around telehealth that's allowed it to blossom and be used in a lot of effective ways. And so thinking about how to balance those two things in the context of APMs is important.
Yeah. Thanks, Carrie. I would like to add one of the challenges that I see as telehealth gets more embedded into clinical care delivery is the point on disparities, particularly the language barrier, and making sure that at the time of the visit that the appropriate translation services are available. And I think it's hit or miss. It's clumsy at times. And what we don't want to do is have telehealth be built up in a way that really creates tremendous burden both on the patient and on the clinician. So I think that's going to have to be well thought through, and how payment for those services gets baked into the model. I'd hate to see where a translation service is obviously needed and it's mandated, but there's really no funding provided for it, which I think has been a challenge in the past for translation services. So I think that this is an opportunity to sort of rethink that. And I'm hoping that as these models get incorporated with telehealth and telehealth gets launched more broadly, that those considerations are thought about early on, rather than creating requirements around translation services and then the lack of infrastructure support to ensure that those services are delivered appropriately.
Piggybacking on the disparities, also is thinking about the types of clinical providers who are able to do these types of visits, and including provider groups like community health workers could also help with the disparities issue.
And Jay, I don't know if we're going to get to it in other segments, but one of the things, and if we are going to cover it in another segment, I'll leave it for then. But I would like to spend a minute talking about the challenge with incorporating the data from a telehealth visit into the record, rather than, I think we were advised from one of our stakeholder commenters in September that we want to avoid creating another silo for data, to sort of sit in the telehealth modules, if you will, and rather than the electronic health record. So I'll look to you, Jay, if this is the right time to talk about that, or you're going to cover it in one of your follow-on segments.
I think we cover it in one of the follow-on segments, but there's no reason we can't talk about it now, because regardless of what we go through, it has to be addressed.
Yeah, I guess the point I'm making is that it would really be, shame on us if we push out telehealth and it just becomes another data sinkhole. And it makes it even more burdensome for both the patients and for the physicians and all of the stakeholders to get access to this information to maximize its potential. I think it could potentially be problematic if we don't really think about it and purposely incorporate how to avoid building out a system for telehealth that would basically inadvertently probably create a sinkhole for data.
Yeah,
that would be a shame.
Yeah, I think especially when you look at freestanding telehealth companies as compared to telehealth being offered as part of an integrated delivery system, where it's part of the service model in that integrated delivery system, as opposed to freestanding telehealth companies that individual patients can access on an ad hoc basis. There are challenges within both of those universes. So I think from a policy standpoint, if we really don't address that up front, we'll end up building a probably potentially larger silo than we've ever imagined.
Yeah, I think this also adds to the prior conversation we just had around fragmentation of care and care coordination being, flagged as really important as we think ahead around payment models. And telehealth has the opportunity to help with that potentially. But as you're pointing out, if it's where the data sits is going to certainly either exacerbate that fragmentation or potentially improve the coordination. So being sure that that's part of the thinking around from a policy point of view, I think is going to be important. And on the disparities, in addition to the language and other issues, and even one of the other challenges is just access to that specialty care often. And so telehealth may be able to, provide some additional access that would be important. But again, it has to be in a way that's integrated from a data point of view in order to effectively coordinate that care.
Thanks, Paul. Before we move on to the next segment, any other comments on this portion? All right, Jay.
Okay.
I'll turn it back.
Thanks, Jeff. Our second category is barriers and enablers to accessing virtual care. So, we need to have flexibility related to coverage and payment in the context of APMs. And from an enabler standpoint, consider research on enabling patient monitoring and other interventions as a form of telehealth. Next slide. So in terms of barriers, there's geographic limits, rural versus urban, state licensing represent a barrier to access, limitations on services covered in site of care for virtual care represent a barrier to access. Currently, there's been an easing of geographic restrictions and expansion of covered virtual services as due to our public health emergency. Provider shortage pose a barrier to access to care in urban and rural areas, especially around substance use disorders. And there's a complexity and uncertainty in coverage for virtual care, which unto themselves represent a potential barrier. And telephone or audio only may be necessary modality to ensure access for some populations. So in the context of telehealth and APMs, we need to consider flexibilities related to geography, site of service, covered services, and provider state licensing. And where possible, seek to provide greater certainty regarding reimbursement and coverage policy for telehealth under APMs during and following the PHE. Next slide. Also, we need to look at chronic disease populations. They often view being symptomatic as part of their baseline or normal, and they may not seek virtual care that can help avoid hospitalizations, emergency department visits, or adverse health outcomes. And telehealth, which is not related to a virtual care event such as remote patient monitoring, can provide proactive care. And these services are not addressed through temporary 1135 PHE waivers. So in the context of new and existing APM models, we need to consider further research to assess the potential of adopting remote patient monitoring and other forms of telehealth in either new or existing models, not related to the existing temporary waivers during and after the PHE. Next slide. So these really barriers and enablers in terms of access and optimization, which we kind of alluded to before, I think, warrant a lot of discussion, not only from geography, specialty, and just integration of all these services that we talked about and not building silos. So Jeff, back to you.
Thanks, Jay. I'll open it up to the committee. Well, maybe I'll jump in, Jay. When you talk about site of service, I think about the traditional visit in an exam room. There's certain privacy and security elements that are incorporated and hardwired into that visit. And I was thinking about, when you're in a situation where it's a telehealth visit, the environment isn't necessarily controlled. And so I think it's something that I'm sure is being looked at. But what are the parameters around protecting patient health information, making sure that the visit is secure? When you're in an exam room with a patient, obviously the patient knows whether someone else is in the room, like a scribe or a nurse assistant, et cetera. But that's not the case in a telehealth visit. So I'm just wondering, did you guys consider, or is that certainly didn't come up amongst the stakeholders, and maybe that's something that we could save for the research side of this discussion, but it is something that as it becomes more ubiquitous in clinical delivery, I'm wondering whether there needs to be some purposeful design around telehealth and protecting the security of the information in those visits. What do you guys think about that?
Well, we looked at that and in terms of a research question, and we address it somewhat when we talk about what are the appropriate guardrails. But I think we do need to be specific, from a HIPAA and cybersecurity standpoint as we move forward. This is just going to be, another data set that we're going to have to manage and protect.
Right.
That's a great point.
And I don't. Go ahead. I'm sorry. Go ahead.
This is Lauren. That's a great point, Jeff. And I think we didn't get really deep into that, but it's so important to think about privacy and confidentiality on both sides of the technology. One of the interesting things we've seen in the data across the country is there's actually been a very big uptake and response to people actually attending behavioral health telehealth visits, as well as substance use disorders. So some of the services have actually expanded access, but it also highlights and exacerbates and makes even more important the confidentiality question.
Right. Yeah. And again, I think this is I'm just calling it out. We're not going to solve it necessarily in our meeting today, but I do think it needs to be highlighted in our recommendation to the Secretary in our final letter.
This is Josh. I just have one other comment about the barriers. I'm struck by kind of, and another thing we're going to solve today, but I do think, telehealth, we kind of group a number of things together. I think what I heard from Jay and others is that, there's audio only, audio, video, and I think just an openness to kind of the idea that SIM may prove in certain settings to be more useful than others, and being willing to kind of focus on the ones that are most effective. And so the barriers will probably look different perhaps across that as the evidence comes out. And the other thing that is, I think, relevant to our committee is this idea of evaluation and the ability to be evaluated. And so there's that tension, at least in my mind, around kind of the flexibility with which people deploy these, and then the ability to kind of come to the other side and say, did it work in some way? And I don't have the answer, but I think we should keep that front and center as we think about barriers.
Mm-hmm. Thanks, Josh. Carrie?
And building on that, in the privacy and confidentiality issues, I think I mean, we're in the United States, we're focused on Medicare, but we're really in a multi-payer environment. And one of the problems we've seen in terms of APM diffusion is also around standard models across payers. And I think that is a problem here too. When each payer has their own set of rules and regulations around telehealth, it really can inhibit expansion of these services. And so thinking about the importance of multi-payer alignment in these services and standards in terms of confidentiality and privacy in terms of the regulation. And then the other thing in terms of barriers and facilitators that struck me was really the importance of the state laws about licensure and parity and how important they are in terms of the use of telehealth across different states. This pre-pandemic, now it's a little bit more similar.
Yeah, great point.
And Jeff, I would just add one other point. This didn't necessarily come up in our meeting or in the comments, but what I've seen over the last few months is an explosion of hospital at home, partially to deal with capacity and carry the COVID cases and really make a proactive system. But that's really going to affect number 2 and the technology and monitoring that there are requests for really deep payment, because I think that shift is going to be permanent.
Yeah, I completely agree, Lauren, and that's going to be amplified. I don't see that going. I don't see that going down. I see that becoming more common practice. So that's a great point.
Yeah, I wanted to.
Any other comments from the committee? Yeah, yes, go ahead, Paul.
I was going to echo that point that Lauren just made. Also saying the shift to sort of care at home models and the explosion in remote patient monitoring and anything from wearables to, in cardiology, obviously, we've been monitoring, pacemakers and ICDs and other devices, and understanding where it's of benefit and who's actually looking at the data, what's the infrastructure build, the cost to monitor that data as it comes in, and then using that effectively, and then thinking through the models where that might be, particularly beneficial. So there's no question that that I think it is beyond the pandemic here to stay. I think there's a lot, and I think emphasized here around research and assessment that needs to be done to understand, the effectiveness of each of those modalities within remote patient monitoring.
Yeah.
I agree with Paul's comments and wanted to add that I think under a research agenda that wasn't discussed here, but just to surface it, are how do we not increase cost within the system? So do we add human capital resources to help with this remote monitoring at home? Or are there software solutions like AI algorithms that are helping to do this monitoring? So there needs to be some assessment of how do we not add cost to the system, but actually, improve value and ultimately expand services without in doing it in a safe and effective way. And so creating measurement of that process is really important from a safety and quality perspective. So that could be another aspect of the research agenda. And the last comment I would make is around this home-based care as a new care model and being mindful of thinking about how do we train the workforce to be able to do that and making sure we have alignment with not in the provider space or physician provider space, GME programs that actually train our future clinicians about how to deliver care in this way would also be a separate and distinct but important research agenda.
Great point. I was just going to raise the issue of storage of all of this information. We're expanding, we're collecting, and we're monitoring. To your point, Paul, monitoring ICD devices and other devices. That's going to continue to put a burden on the storage, and gets back to my earlier point about security. Where is this information going to sit, and how are we going to store it in a way that's going to be able to essentially expand as the information expands, so that it's still accessible and it's still usable, and that's something that we probably should incorporate in our letter as well. particularly security. If it's not, right now there's very robust security parameters around sort of the traditional electronic health record and the visits, et cetera. But I'm not so sure that's the case in the telehealth world as it expands and other vendors get into the space. Do they have the same robustness and parameters around security and access, et cetera? I know that when you work in health systems, you know, you have auditing abilities to actually look at who's accessed the data and do they have the appropriate permission rights to do that? And there are recourses that can take place. I'm not sure that all of that's being built in the telehealth universe. So that's something to think about. All right. Any other comments before I turn it back to Jay? All right, Jay.
Okay. Let's move on to category 3, which is payment issues. You know, and how do we, you know, to document our emerging findings, how do we use APMs to enable telehealth, and how do we leverage the insights from our previous PTAC proposals? Next slide. So some of our key observations, in fact, were providers that are engaged in APMs were able to adapt quickly and pivot to virtual care under the COVID-19 PHE. And that APM models gave providers more flexibility, sometimes through prospective and risk-adjusted payments, which we had discussed earlier, to adopt the virtual care modalities. And then we need to consider highlighting best practices and findings from rapid adoption of telehealth among providers involved in APMs across provider settings and clinical scenarios, standalones, substance use disorders, or behavioral health, as well as the usual source of care. And this kind of just dovetails to Josh's comments earlier. Next slide. You know, virtual care delivered under APMs can be a tool to help ensure continuity of care, avoid exposure and avoidable utilization, ED and inpatient, especially in the PHE environment, and support provider-provider coordination. Flexibility afforded through prospective payments and risk adjustment can support flexible adoption of virtual care modalities. And additional evidence is needed regarding the impact of telehealth on cost, access, and quality for various services. We need to consider including telehealth modalities across all APMs currently in testing or development as tools for facilitating access to care, optimizing care delivery, reducing avoidable inpatient or ED care, improving health outcomes, improving provider coordination, and supporting provider teaching, education, and collaboration. And we should consider using ACOs or other models to assist in testing the impact of telehealth on cost, access, and quality for various services. Next slide. You know, our 18 previous PTAC proposals included telehealth as a component of their models. Some of these proposals included innovative care delivery models related to providing remote assessment and education to rural providers relating to neurological conditions, telemonitoring of patients with chronic conditions, providing team-based care to multiple skilled nursing facilities, ensuring care coordination after discharge from EDs, and maximizing primary care provider flexibility. ACO shared savings can potentially be used to support cost-saving telehealth interventions. So by reviewing previous PTAC proposals that included a telehealth component and incorporate some of the telehealth-related elements from one or more of these proposals into ACOs and other CMMI models that include prospective payment and two-sided risk in order to pilot test potential best practices and assess their impact on healthcare costs and quality. Next slide. So really, you know, when we start to talk about payment issues, these were the key ones that came to light both on the discussions during our September 16th model, and I also think we've got additional comments from Lauren and Carrie on these as well.
Thank you, Jay. This is Lauren. I think one of the interesting things in this arena is, especially with behavioral health, we've seen a tremendous drop in the no-show rate. And it also brings up with behavioral health and substance use disorder, what is a patient's usual site of care? So often with those services, they're seeing those providers many more times than their primary care physician. So it starts to expand the dialogue about usual source of care, how that care is funded, and how the data is integrated.
Thanks, Lauren. Carrie, do you have a comment? Maybe I saw your hand go up. Maybe it was a shadow. Sorry about that.
No, not right now. Thanks. Great job, Jay.
Jeff, for additional PTAC conversation and discussion.
All right. Payment. This is a big issue. I'm happy to jump in, but would love my colleagues to go first. If there's any comments here. Well, we touched on it earlier about, I think it was you, Jennifer, talked about all payer. And I think really that's going to be, to some degree, the secret sauce here is to get commercial payers to partner with Medicare and create an intelligent framework for payment. I think that the variability in payment now for telehealth services, and particularly when the pandemic washes out, it has the potential to be really problematic. And I think this is the opportunity, and my preference would be to get it right. And again, not saying that there can't be any flexibility or variation, but I do think it is the opportunity for the commercial payers to really think about how to pay for these services, what's incorporated, what's not, some of the items that we've already touched on as it relates to elements like disparities and translation services, et cetera, not to revisit that. But I do think that the biggest barrier to uptake in telehealth could be simply payment. And I think it could be a huge, compelling accelerant to further adoption, but it could also be a huge detractor. And specifically, you think about physicians and whether they're in small practices or big systems, there's a lot of infrastructure that has to get built to support telehealth. We talked about some of those items today: storage, security, et cetera. And it would be a shame to build that infrastructure, which is a long-term play, and not have a payment methodology that really supports it. And I'm not saying a reckless payment methodology. I think from a payer's perspective, that's always been the question mark is, how much control will they have on costs if telehealth sort of just gets, becomes a free swimming environment. And we're not suggesting that, by the way. But that's, I think, one of the risks that the payers have been resistant. Even Medicare, to some degree, has been resistant on sort of, and allowed them to sort of govern the use of telehealth. I think now's the time to understand the value of telehealth, the real value that it brings, avoiding emergency room visits, avoiding all the pain points for patients who have limited opportunities for transportation. And being able, from a provider standpoint, to be able to make those communications with patients and their caregivers more of a real time than trying to go through the scheduling and appointment morass that some folks have to struggle with. So if I could just back up, I really do think payment is as much of a barrier as it is an accelerant to telehealth adoption. And I think we need to get it right as best we can.
Yeah, Jeff, hi, this is Paul. I absolutely agree with that. And thinking back in several of the proposals that we reviewed that had sort of this baked in, just a few comments is around payment. I think one of the challenges was in several of them, there was the proposal for a prospective payment related to, building the infrastructure and managing the telehealth. But then when it came to the two-sided risk, it was often, there was on the specialty side, there was a reluctance to sort of think about total cost of care. It was often around the care related to that specific condition. and reducing either ED visits, et cetera, around that specific condition. I think that's one opportunity to explore further is I think there needs to be that prospective payment for all the reasons we've talked about to build the infrastructure and build the integration within the system so that it is coordinated and not fragmented, but then tied to in a value world to a two-sided sort of total cost of care, and think how that more broadly how to do that again with the challenges of engaging specific specialties, but within that, I think it spans that whole discussion around fragmentation of care and care coordination, and patients don't just have one condition in order to really build a platform that'll work.
Thanks, Paul. That's helpful. Any other?
I want to agree with your.
Go ahead, Jen.
Yeah, this is Jennifer. Yeah, I want to agree with the comments and just call out that currently there's a perverse incentive with our payment system that encourages care to be delivered on site. So both the technical component and the professional component. And in organizations, where there is potentially not alignment, so two parties involved in care, which is, the process or relationship for many current, health systems and provider groups, there is financial disincentive to not have facility-based care. And so I think exactly to your point, not only the comments around, multi-payer, but site of service is also something to be considered. And then in your comments, I just wanted to re-emphasize around infrastructure are critically important. And so we've had other payment models and programs. Meaningful use is obviously one that comes to mind, where there was acknowledgement that there's a big upfront infrastructure cost that's required. And then there was an alignment of incenting the development of basic infrastructure to get everyone sort of to jump from curve A to curve B around a new care model and delivery model. And so I think thought has to go into, and maybe it's this prospective payment, which is what we've seen a lot of stakeholders recommend in the models that we've seen going forward. But that has to be addressed because I agree the payment model is what will keep from developing a patient-centered care model, which COVID has clearly shown that virtual care services are a patient-centered care model.
Yeah. Thanks, Jennifer.
And then just to build on.
Comment? Lauren, go ahead.
This is Lauren. Just to build on what Jennifer said. And so the dialogue also has been loud and advanced around who actually gets paid for the telehealth visit. So as the care is rapidly disseminated into the community in the home, social workers, nurses, pharmacists, community health workers, there's interprofessional care and really determining who's best to do the visit and how does that fit in the payment model. Total cost of care and the APMs help, but that question isn't going to go away if we look at it through the patient's eyes about what they need and how do we efficiently and effectively deploy the technology.
Good point.
And just adding on to Jennifer's point about the, the site is, the payment differential. There's also payment differential in the in-person visit where there's often other ancillary services that are provided, which provide additional payment into the system which is not there in a telehealth visit. So, again, just highlight some of these differentials on payment between virtual and in-person.
Thanks, Paul. Jay, we may toss it back to you for research.
Okay. All right. Next slide. Well, as with any robust discussion, we often end up with more questions than answers. And telehealth is no different. So we've got a fair amount of research opportunities and questions based on infrastructure, beneficiary and provider needs, standards for adoption, and barriers and payment issues. So we'll get right into it. Next slide. Consider sponsoring a report on unintended consequences associated with widespread adoption and use of telehealth that addresses the exacerbation of disparities in care for specific populations due to the digital divide, cognitive and physical impairments, LTSS needs, and for those living in the community with limited caregiver support. How can the needs of these populations be addressed in the context of telehealth and APMs? And what features of an APM will or will not facilitate helping these populations benefit from access to telehealth? Next slide. Consider research on unintended consequences of widespread telehealth use on populations, including those with impairments or those who require language translation and culturally competent education. How can the needs of these populations be addressed? What features of an APM will or will not facilitate helping these populations benefit from access to telehealth? Next. In the context of APMs, what types of partnerships with a diverse array of stakeholders, including providers and those representing beneficiaries, support the development of standards for telehealth adoption, including workflow, service integration, team-based approaches, shifting to a culture of routine access and interoperability of data gathered in the context of telehealth? And what is known about the standards of care, quality, measurement, safety, and appropriateness in the context of virtual versus in-person care? And what are the best approaches for determining services where there should be payment parity between in-person and virtual care? And how do we account for differences in the care environment and incentives inherent in virtual versus in-person care, while also maintaining simplicity and flexibility? Which telehealth interventions are different modalities, settings, rather than a new type of service? And are there program integrity challenges associated with telehealth? Next slide. In the context of APMs, explore research on costs associated with beneficiary access to broadband connectivity and technologies and technical support needed to benefit from telehealth. How, if at all, should APMs incorporate cost of implementation and effective use of telehealth into their payment design? How do different APM payment designs facilitate or create barriers to effective adoption and use of telehealth? And what supports do beneficiaries receiving care through APMs need to most effectively benefit from telehealth? And how does beneficiary satisfaction vary for specific services delivered virtually versus in person? Next slide. In the context of new and existing APMs, consider further research that could assess the potential of adopting remote patient monitoring and other forms of telehealth not related to existing temporary waivers during or after the PHE. And how does the role of telehealth vary if the intervention is a substitute for in-person care versus a complement or supplement to in-person care? And how should coverage and reimbursement rules vary for these different forms of telehealth? Next slide. And consider highlighting the best practices and findings from rapid adoption of telehealth among providers involved in APMs across provider settings and clinical scenarios, whether standalone substance use disorder, behavioral health, as well as usual source of care. And what are the reasons for and against the inclusion of telehealth in different types of payment models? What are the best approaches to understanding the true cost of adopting different telehealth modalities? And what are the models of payment that will make these financial investments feasible? Next slide. So these are a lot of questions for us to take up, and I'm sure there's more that'll come out of our active discussion of these areas. So Jeff, I'll kick it back to you for our last go round here.
All right, Jay, nice job. So maybe Lauren, Carrie, you guys were Jay's partners in this. Did you guys have any specific comments that you haven't already made relative to this last item around research questions and gaps?
Just generally in terms of like silver linings of the pandemic, what an opportunity we have to learn. about telehealth based on what's happened in the last 9 months. So I'm very interested to see. I think we'll know a lot more in the next year about telehealth than we do now.
Great.
Agree with Carrie, and it was well covered by Jay.
Super. Bruce?
I guess I'm thinking of the pre-COVID world and how much do we already know? I accept that we'll know a lot more from the COVID experience, but let's say how integrated delivery systems have used telehealth versus how that contrasts with how telehealth is rolled out in an uncontrolled fee-for-service system. Do we have much information about that at present?
Anyone? Jay?
I don't know the answer to that question. I think we know the volumes have increased so dramatically that I think, most things operated at a much lower volume pre-pandemic. So I don't think necessarily a lot of attention was paid to it. But obviously, I think with the tremendous increase in volume and utilization, we're going to get a lot more answers in a lot faster time frame.
And Bruce, I think there's two drivers, so it's difficult to differentiate where it grew. So people in APMs were really driven to control costs, and so rapidly building that into their service was really important. People who lost fee-for-service revenue from the lack of in-person visits were equally driven to build it out very quickly. So I've seen a pretty broad swath growth across the country in both buckets.
So be patient is the answer, I guess.
Jay, I wanted to maybe just pivot a little bit, but it is still in the research category, and that is related to, education of medical students and residents on telehealth. We have a very well and very thoughtfully designed system to train for medical education, clinical staff. It's not just physicians and medical students, but also all of the folks, all of the stakeholders that are in the pipeline for care delivery. But when it comes to telehealth, I'm sure that there are opportunities for standardization. That was something that you raised earlier, and education, and also some of the parameters around signing off. If residents and students are involved in telehealth visits, how do we ensure that they're conducted appropriately, that there's clinical oversight and that's appropriate, and all of that's sort of factored in, and then how to charge for those particular services. Those are all complicated. Those are all complications that we struggle with as it relates to education in a traditional practice setting, and I think telehealth just adds another layer of complexity.
It definitely does, and the answer to your question is yes, 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 and yes. In fact, we're trying now as we rotate students through outpatient primary care centers. As part of their experience, they're with their attending. They're now doing virtual visits as opposed to in-person visits, and we're kind of taking them through the logistics, of how do you operationalize it, what's a visit look like, but again, building on the foundation of in-person first, but a lot of all medical schools had to switch to a virtual environment for, traditional first and second years. And in the third year clinical experience, many medical schools had to go to virtual for the third year because when the pandemic first started, the hospitals were short on PPE and they didn't really know how to handle it. So a lot of third year medical students were kind of kicked out of the clinical setting from March to about July. And all medical schools had to adopt to a virtual environment. So it's kind of part of the process now. And we're trying to figure out, how do we put the standards around it from an educational standpoint? And to Jennifer's comment earlier, I mean, the whole future of GME is going to be altered as more and more care is delivered out of the hospital. I mean, hospitals are traditionally the delivery of graduate medical education from a residency standpoint. But as more and more care is in the home or various settings, how do we address that from a residency training perspective and a funding perspective? So, you know, there's tremendous opportunity, but there's also tremendous challenges that are before us.
Agreed.
I think, Jade and Jeff, another competency too is how to maximize efficiency in the visit and interprofessional integrated care. So I've watched sites around the country how they organize that visit and integrate different disciplines and how they're doing it well. That will become even more important in GME as well.
Thank you, Lauren.
And Jeff, this is Paul. This is maybe a tangential comment, but I'm thinking about the Cures Act and the move to greater transparency around notes. And so you can imagine going forward in this world where the notes are now, the encounters will create notes but patients will have access to. And so it'll be another impetus to thinking how best to coordinate care as well.
Yeah.
You know, the only thing I would add, Jeff, is I think from a research perspective, we really need to incorporate what you brought up earlier in terms of cybersecurity and data storage and how to protect this arena as it just grows exponentially over the next 2 to 3 years.
Mm-hmm. Yeah. So we'll definitely bookmark that. I thought maybe where you were going to go, Jay, is that outcomes, how do we measure? There needs to be some standardized approaches to measure outcomes of the effectiveness of telehealth on all of the disease states. There's a lot we don't know about how effective telehealth is. We have some good ideas in some areas, but there are long-term, because of its uptake in the last year, there's some long-term outcomes that are still unclear. And I think that needs to, I'm sure it's already being looked at, how effective telehealth can be, not only on the cost side, but also on driving quality results and reaching a lot more folks. So I think there's a lot of research that's going to come out to really explore outcomes over time.
Agreed.
This is Josh. I would just build on Jeff's point and say that I think that reflect on what Jay was sharing about how students and trainees are, they're having to kind of implement, learn these kind of televisits. It strikes me that even before maybe the surge related to the pandemic, that there was variation in how different attendings and clinicians delivered care, make that doubly, triply so in the world of telehealth. And so I think without those outcomes, Jeff, it's very hard to, I think for learners to say, is this just variation between, supervisor A and B, or is there outcomes to say it, quote, ought to be done that way? And I think that's going to be really critical if we're serious about this research thing that we've been talking about for the last 10 minutes.
Well, I think we should be serious about it. Reason is the cost. I mean, the expansive use of telehealth going forward, and even baking it into payment models, we need to know how best to deploy it to maximize its potential and effectiveness. So that's definitely something that I'm hoping we as a system, a healthcare system, figure out sooner rather than later. Getting underneath outcomes has historically been one of the foibles for our healthcare system, and so I hope that it doesn't take as long on the telehealth side as it has for traditional practice.
But I think we have to also recognize there's often not a direct line between one, like a telehealth and an outcome, right? Just like, we know care management is good, but the direct line between care management and outcomes for years of lots of research is mixed. So it's going to be difficult, but to reemphasize the cost piece and the payment piece and how to tie that to maybe more global outcome, I think we would require more research and also thinking about how to get there.
Agreed. So Jay, Carrie, Lauren, really, really nice job. You guys took in a tremendous amount of information, had to distill quite a bit. I appreciate the fact that you've been able to present it to us to spark the conversation that we just had. It's going to help us provide insights to the Secretary in a way that hopefully will be very valuable. Before we wrap up this section, I'd like to ask Audrey, who's been listening intently to our comments, if she could provide a brief summary on some of the key points of our discussion before we close out this section and move on to the public comment section of our public meeting today. Audrey? You might be on mute, Audrey.
Yeah, sorry about that. I had to unmute myself. So I'm going to give you a summary of what I heard, and this will hopefully provide a basis for the information that will be included in the report to the Secretary. So in terms of overall comments, it sounds like the committee believes that telehealth, which includes a variety of different services and modalities, can be an important and effective tool for optimizing the delivery of healthcare, and also that the increased use of telehealth during the public health emergency provides an important opportunity that can be leveraged to hopefully increase the role of telehealth in the delivery of value-based healthcare where appropriate. With regard to the challenges that need to be addressed in the context of telehealth, there are a number of challenges that the committee has identified. These range from barriers that have affected beneficiaries' access to and ability to use technology relating to telehealth, issues specifically relating to vulnerable populations, the need to develop standards and best practices and quality measures for telehealth, the importance of understanding the actual costs of providing telehealth services, which is important for being able to develop appropriate payment, the need to as well address issues related to coverage of telehealth, such as which providers should be covered, and issues related to site of service and things of that nature. Additional challenges that were raised in the discussion also include the tensions between increasing access and program integrity concerns, determining the efficacy of telehealth across services, also the balance between providing flexibility and administrative complexity. And also there was a lot of discussion about the upfront infrastructure costs related to telehealth and the variability in payment. So in addition to the specific comments that were included in the PCDT's presentation, the report to the Secretary will synthesize specific comments that were made as part of this discussion. And in particular, the committee members discussed the potential role that APMs with prospective payment mechanisms can play in giving providers flexibility to use telehealth effectively, also testing the impact of telehealth on cost, access, and quality for various services, and ensuring that telehealth is not overused. We also heard discussion about the importance of understanding which issues may be more relevant for different kinds of models in the context of APM, such as primary care versus specialty models. The importance of addressing disparities, including disparities related to language, and ensuring that the cost of addressing these disparities, such as translation services, are included in the payment upfront. Additionally, discussion around the types of providers that should be providing telehealth services. One example was mentioning perhaps community health workers. The importance of improving care coordination, avoiding fragmentation of care, and avoiding creating another data silo related to telehealth. The importance of protecting patient health information, a lot of discussion around that. The importance of evaluating which modalities are most effective in addressing some of the specific barriers that have been identified. Implications of the increase in the use of hospital-at-home models and remote patient monitoring, and the need for research on effectiveness and strategies for not increasing costs with the use of these services. Additionally, discussion around developing appropriate payment models for telehealth and reducing variability across payers. And finally, the importance of getting information on telehealth outcomes, which also has implications for cost of these services. So those are some of the major themes, but staff will also be reviewing the transcript and incorporating all of the, the rich discussion that we heard during this deliberation. I think you're
Jeff, you're on mute.
Okay. Thanks, Audrey, for that great summary. I'm glad you're able to keep up with us. That was very helpful. Appreciate all your support. We are going to close out this session. Any final comments from the committee before we move on to the public comment section of our meeting today?
No, I just wanted to say thanks, Audrey, for getting that all down, and also for all of the work by ASPE and NORC leading up to this. Jay did a great job presenting it, and they did a great job coalescing it. Thank you.
Agreed.
Completely agree. Wholeheartedly. All right.
Thanks, everybody.
Yeah, you're a rock star, Jay. So we're going to move into the public comment section. We have three folks signed up. They each have 3 minutes. I'm going to go ahead and introduce them, and the lines will be open. We're going to start with a former PTAC member, Harold Miller, who's the president and CEO for the Center for Healthcare Quality and Payment Reform. Welcome, Harold.
Thanks, Jeff. It's nice to be with you. Hello, everybody. Congress created PTAC for one very specific reason: to increase the number of physician-focused payment models in the Medicare program. PTAC has failed to achieve that goal since none of the models recommended by PTAC have been implemented by CMS. In most respects, the process established by Congress worked extremely well. Dozens of physicians and specialty societies developed excellent proposals for payment models that would improve the quality of care and reduce Medicare spending, and PTAC recommended 17 of those models for testing or implementation. However, despite that huge investment of time and effort by both the applicants and the members of PTAC, CMS has refused to implement any of the models that PTAC recommended. This is not because CMS found better ways to implement physician-focused payment models. 5 years after the passage of MACRA, most physicians in the country are still unable to participate in an alternative payment model. This includes both primary care physicians and specialists. Moreover, the APMs that CMS has implemented have been failures. None of the Innovation Center models have resulted in net savings, and the Medicare Shared Savings Program has only managed to reduce spending by less than 1% after 7 years of trying. A major reason the CMS APMs have failed is because they are not physician-focused. Unlike the models PTAC has recommended, CMS APMs have not addressed the problems in the fee-for-service system that prevent the delivery of high-valued care. Increasing the level of financial risk in bad models will make them worse, not better. Because it is now clear that CMS ignores all recommendations from PTAC, no one is even submitting proposals to PTAC anymore. It has been more than 9 months since PTAC received its last proposal. The people who should be most concerned about this are the members of PTAC, yet you have remained silent about the problem. Over the course of a 2-hour meeting this morning, there has been no discussion about the failure to implement PTAC recommendations or what should be done to address it. As the saying goes, silence implies consent. PTAC was not created to serve as a forum for stakeholders to convey their ideas and concerns, as you have suggested in your vision statement. Congress created PTAC in order to increase the number of physician-focused APMs. So if you really want to achieve that goal, I recommend you do two things. First, you should begin providing data and technical assistance that will help stakeholders develop more and better physician-focused APMs. Most of the comment letters you received asked for this, and you have $5 million in annual funding to support it. When I served on PTAC, we tried to do this, but HHS lawyers said PTAC had no authority to do anything other than review proposals. Apparently, that restriction no longer applies, however, since PTAC has spent the past 6 months talking about telehealth issues that have nothing to do with actual proposals. If HHS continues to prevent you from providing data and assistance to stakeholders, you need to speak out publicly about the problem. Second, you should ask Congress to change the law so that CMS is required to implement the models that PTAC recommends. Over the past 9 months, CMS has implemented many major changes in payments and new alternative payment models. This makes it very clear that the failure to implement the models PTAC has recommended is a lack of willingness by CMS to do so, not a lack of resources or ability. Only Congress can change that, and the members of PTAC need to publicly support that change.
Thank you, Harold. The next public commenter is Dr. Etienne Sabel.
My comments are on the financial aspect and the technology aspect of telehealth. Those ideas are outlined in my PTAC proposals of 2019 and 2020, and I will be happy to explain them in great details outside of this venue. Telehealth could turn out to be very expensive. For years, insurance payers were concerned about overutilization of telehealth, delivering high volume of low-value care. Nowadays, the pandemic has made telehealth popular. It is about safety, and therefore telehealth is here to stay. But it does not have to be a money pit business. Efficient telehealth could deliver great care and dramatically cut costs. So what is efficient telehealth? Efficient telehealth is done in the setting of a medical team, acting as one body without duplication of care. For example, physical examination could be performed by one member of the team. Efficient telehealth cuts unnecessary transitions of care and eliminates unnecessary steps of transition. Efficient telehealth allows continuation of care regardless of location, and therefore team member will provide care after the transition. In essence, transition of care will become, in part, continuation of care. It will be efficient and less expensive. A team approach to telehealth requires integrated technology. So what is integrated technology? Integrated technology provides roads and bridges for information and communication. We have a unique opportunity to correct our mistakes of the EMR implementation era. Integrated technology will be owned and shared by all of us and will promote vertical thinking, allowing care of multiple patients as opposed to the horizontal thinking of the current EMRs. Integrated technology will open the market for competition. Competition reduces monopolism, increases patient choice, promotes better care and efficient care. Integrated technology allows innovative new coordination of care mechanisms and new payment models. Those ideas are independent of our debate about single payer versus multiple payers. In my PTAC proposal, I speak about regional referral centers, or RRCs, as a tool to decrease cost and promote competition, which you are welcome to read about. To summarize, efficient healthcare and integrated technology could be the keys for better care, enormous cost saving, and avoiding the money pit business of telehealth. Thank you.
Thank you, Dr.
so much.
Thank you. And finally, we have Dr. Larry Kaczynski. the Chief Medical Officer of Sonar MD. Well, I want to thank everyone for participating today, members of the public as well, as my colleagues on the committee. We explored many different facets of telehealth and also laid down some of the groundwork for future changes to come. You can keep an eye out for the resulting reports and any of other announcements by joining the PTAC listserv available at the ASPE PTAC website. I want to thank you all for taking time out of your busy schedule to join us today. Please take care, be well, be safe. And the purpose of today, the meeting is adjourned. I would like to say to my PTAC colleagues, if we could reconvene at 12:30 Eastern Time, give people a bit of a break, that would be great, and look forward to talking to you. Again, thanks everyone. This meeting is adjourned.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.